Our next speaker is representing the year 2022. And she has listened to, very specifically, 2,555 hours of podcasts in the past calendar year. And she's looking for suggestions if anyone has any. Please welcome Ipek.
Good morning, everyone. I just realized I'm what stands between you and lunch. But I still have 20 minutes. So there we go. So before I begin, here are my disclosures, and I'd also like to acknowledge my collaborators who have been involved in this analysis with me, Ms. Leventhal and Dr. Nukawarpu, who are both a member of my lab. And the data that I'm going to share with you today come from a larger, still ongoing study that is funded by the NIH. Now, I'm going to start by motivating the clinical scenario upon which this talk is built, which is female reproductive health, and specifically chronic pelvic pain disorders. Now, this endeavor is just another Thursday for me, but that might not be the case for some of you. So if you are wondering why this topic matters and why some of us think about it all the time, the next slide is for you. Female chronic pelvic pain disorders include conditions like endometriosis, adenomyosis, uterine fibroids, and so forth. I will not get into the whole clinical etiology, but what you should know is that if you don't have one of these conditions yourself, the chances are someone in your life does. So they're quite prevalent worldwide, and they have high individual and societal impact, both in terms of the healthcare costs associated, comorbidities. They account for a large number of hospitalization hysterectomies. So it is very costly. And all of these issues we have known for some time. Like, we did not just discover all these problems. And despite having known all these problems, all these gaps, they're still persist. No, one of the reasons why we don't have a good way of still not treating well and kind of ignoring or not being able to identify sooner is because we understand, our understanding of these conditions is just very, very poor. We don't really understand how they happen, what treatments may work. So it remains a bit of a guesswork. And one of the reasons, again, for this gap is that these conditions are very poorly documented in standard clinical records, namely the electronic health records. And this is the reason this becomes important is because EHR still remain a primary data source for most of medical research. So if you have sparseness or missingness in the data source, it trickles down at the subsequent stages of the research. And this is a missed opportunity, not for the sake of being able to better treat and address these conditions, but also because we're now finding out that this is some of these symptoms can be a marker of overall health later in life, such as cardiovascular disease. So there's a lot of value in putting more effort into identifying some better working solutions. Now, this is where mobile health technology can come in very helpful. We can augment the existing data sources via various mobile health technologies, such as research-based apps for self-tracking, as well as various wearables and sensors that we might integrate. There is some evidence that direct patient input into the existing clinical data sources can help us capture real-world data and help make better decisions, maybe predict flare-ups, treatment outcomes, and so forth. So things like routine outcome monitoring of responses, because we know that the patient spends relatively so little time at the doctor's office, but their disease unfolds when they're outside of the point of care. So we want to capture some of these nuances, and as well, we want to be able to address the variability across patients that unfolds over time, because those could be informative for the clinical decisions that we would be making. And again, because these conditions still don't have a good standardized, established way of treatment, self-management of the patient's symptoms is very central, especially for these cluster of conditions. Now, to deliver on the promise of this mobile health technologies, however, we need to be mindful about the unique features and the challenges that such data bring about, such as the temporal complexity, right, compared to some of the other classical data sources. We have these longitudinal intensive sample data, Again, they also have their own missing patterns, and these missingness patterns could vary, again, across individuals, across the different data sources. And again, you have the multimodality of the data. So then we have this question of how do we meaningfully harmonize, combine, and summarize these different data sources so that we can actually make clinical decisions at the point of care, right? Now, all of these collectively set the precedents for the work that I'm going to share with you today. I'm going to demonstrate how some of the ways that we can handle such data towards better understanding specifically female chronic pelvic pain disorder patients and their day-to-day symptomology, the fluctuations, how they might interact with each other. And in addition, I'm going to look at some health behaviors, some lifestyle factors that could be again, associated with some of these outcomes. And for our purposes, I'm going to use physical activity and its subset of exercise as an example. Now, quick retour, why physical activity and exercise? Because we have evidence, preliminary or prior evidence that exercise can be an effective pain management technique for a variety of chronic pain conditions, as well as in chronic pelvic pain disorders, even though it's a small body of work. But the preliminary evidence is either just a single data point of cross-sectional, or we also did some work looking at day-to-day levels and fluctuations, so single bouts of exercise and single reports of pain. But we still don't know if there might be a trend if you expanded the time interval. So for example, weekly, right? Like, is there an additive effect, the weekly volume of the activity? So that'll be the precedence. Now, which brings me to, let's talk about the data sample and the analyses. Now, the sample for the study include 68 individuals who have a clinically diagnosed chronic pelvic pain disorder. They each have 90 days of data, so that totals to about 4,000 person-level days of data. And because it's prospective data collection, we were able to control for a variety of things like comorbidity. So none of those individuals have any major comorbidities that they're under treatment, that they're currently under treatment for. They're mostly employed, urban dwelling. So some of these details are important to contextualize the results that we'll see later. My data sources include self-track symptoms from a research app, eHive, that was developed by our team in our department, and we're using Fitbit devices to collect continuous physical activity data. Now, first things first, the surveys that I mentioned that come from the app, what are some of these surveys? There's a whole host of them, but I included some of them that might be relevant for our purposes. They're mostly pain-related, so end-of-week pain reported by the individual, but it asks for their current pain, so end of the week, as well as pain interference, so which that is asking how much their pain symptoms are interfering with their day-to-day activities. We also have physical function, again, their ability to carry out daily activities that they need to carry out to go about their life. We have the PROMS Global Mental Health, which is a measure of depressive and anxiety-like symptoms. Now, we like these standardized questionnaires because they have been benchmarked against clinical endpoints, and also we have clinically meaningful cut points that allows us to make a little bit more contextualized inferences once we have the results. And then for the parameters from the variables, I'm using steps and moderate to vigorous intensity physical activity. And for MVPA, and that is because we have evidence that that subset of activity is has been associated with favorable health outcomes, such as better cardiovascular health and as well better mental health. So that will be our focus. Now, we can, as a first glance, we can plot some of these data and kind of look at the distribution. As you would predict, having 4,000 data points and what have you, it'll look all over the place, very scattered. And I also added some measures of variability, both within and across individuals, because I do not expect all of these proxies, all of these measures to wildly vary over time. For example, things like self-efficacy or some of these other measures could be more stable over time, as in some cases that might be the case. But you would still then expect variability across individuals, just because there's some inherent differences in how different people use a given scale. So my value of a score of 5 on a pain scale might differ from your score of 5 on the same pain scale. So, okay. And the taper in the beginning and in the end of the plots is just because of the retention. There are fewer people towards the end of the study, the typical dropout, and so forth. Okay. Now, just to give you a snapshot, this is what my study data looks like for some of the analyses. Now, each row in this case is one person level week. So remember, I have the questionnaires once per week at the end of the week, so that's one row, and then I have continuous daily physical activity data. So I have those 7 days of data that correspond to, right, that precede, that go up to the last day of the week where they did the questionnaire, right? So I want to be able to analyze the structure intuitively to give you a sense. So some of the considerations that I have, again, I have missingness in these data, or if it's not missingness, I do have some zero inflation potentially, especially with the MVPA, because not everyone engages in moderate to vigorous physical activity, so those will be zeros, and then you have a lot of zeros. Sometimes the models don't do so well. Again, I have repeated measures, and I want to be able to account for the variability across individuals, so the random effects, right? So it's all of those things I want to be able to do. Now, going back to the variations, remember, we're looking at, in our case, physical activity as our example, and how that might be associated with some of these symptoms. Now, you might remember from the previous slide, even though some of the measures did not vary as much, there is actually a lot of within individual variability in physical activity, which is interesting. So I don't know if it's unique to the sample, but that was interesting. So okay, so again, I want to be able to account for the individual level variation, and there could potentially be nonlinear relationships, right? I want to capture that, but going into the models, I don't know what type of a nonlinear relationship. So I can't really, I don't have enough prior information to specify a shape. And then, as I mentioned, I want to smooth out those 7 days of data in at least a part of my analyses so that I can analyze them together, right? So I'm going to smooth them out. I feel like I'm in a baking show. You smooth out the cake. So there we go. Okay. So analytic approach. So we'll be, as I alluded to or foreshadowed, I'm going to use some smoothing functions. So what I'm going to rely on primarily 2 R libraries, the MGCV, which is for generalized additive models or generalized additive mixed models. And that primarily, for our case, they allow us to capture complex relationships. And again, they help us to do all that smoothing that I mentioned by using basis functions, right? The second package is the refund package. Again, it is very similar to the GAMS, but what additionally it does is it allows you to take those 7 days of data and then convert it into functional predictors. So then you can then interpret the point estimates together, right? For those, as opposed to just having 7 discrete data points. And then it's using a spline basis to express the regression function. Okay. Now we'll look at 2 models. In one of them, we will look at MEPA as a predictor of global mental health, at the end of week global mental health. And in the second model, we're going to look at steps as a proxy for total overall weekly volume of activity as a predictor of pain self-efficacy. For that one, I selected that one because there is some rationale and some evidence that an individual who is able to, since these measures are recall-based, if they have been more active, regardless of the purpose of their activity, that they might perceive their ability to go about their day-to-day in a more improved, a higher, and a greater sense of self-efficacy, right? So that's their ability to go about their day despite all the symptoms and pain they might have. Okay. And then in addition, I'm adjusting for some covariates, as I mentioned, because there is some variability in participation in or tracking data availability, time, and study. I also include adjust for natural time. So this is cyclical encoding because there might be the time interval between the data points could vary. So that accounts for if there were missingness or if some people completed the end of week questionnaires on maybe at different time points, it encodes for that. And then I'm also adjusting for current pain because we found out that people's ratings of some of these measured perceived outcomes are actually associated with how much pain they have at the moment when they're filling out the questionnaire. So we want to partial out that effect so that we can look at the variation brought in by our primary predictor of interest, which is physical activity, and some of the other linear predictors. Okay, so now let's look at the results. Okay, so first we're going to look at weekly MEPA and mental health ratings using the global mental health scale. What you're essentially seeing, so if you are a visual person, you can look at the figure point estimates in the middle. The table on the right it's the same. So if you're a numbers person, you can look to the right, otherwise in the middle. And then on the left side, we're looking at the general trend for looking at the association between MEPA and mental health, estimated mental health scores. What we're seeing as we hypothesize is that there is a bit of there is a relationship between the two where more volume, more amount, or more minutes of MEPA is associated with better ratings of global mental health. It's not necessarily, it doesn't look linear thus far based on our ongoing interim analyses. Now, one interesting thing that we did, and this was my student's idea, is we adjusted for pre-existing psychiatric diagnoses of depression and anxiety. And what we find, so the significance of the primary predictor is after adjusting for that. So regardless of that pre-existing condition, we still see this effect. Okay. So these were the fixed effects. Now these are the random effects. As I mentioned, we also want to capture the between individual variability. On the left, those are the point estimated random intercepts. So each blue dot is one individual, and the gray lines are the confidence, the 95% confidence intervals. So as we would predict, as we would expect, there is variability between individuals. And the lattice plot on the right is just, they are small, but just to show you, they look different. So there are differences between individuals. It's plotting GMH against MEPA. So for the second results for the second model, the linear penalized functional regression. Now what we found here was, there is, again, as you would expect, there is significant differences across individuals, so significant random effects. The linear predictor, so we have, we adjust for baseline pain self-efficacy here because, as I said, sometimes it can be a trait and they could, it can influence the subsequent measures of PSEQ for an individual, so we do adjust for it. We partial out that variance, we adjust for time and study. And we still see that there is some effects for steps, so that's the first figure. It's not terribly, so this wasn't as significant, that the coefficients were not as significant, so which is not very surprising. The main reason we wanted to use this model, again, is so that we can actually accommodate that data structure of having 7 days against one, once per week outcome. But there does seem to be a total volume effect. So those who are more active out and about during the week do seem to feel more self-efficacious despite their pain symptoms. Now that figure on the bottom right, I did try, you might be wondering, this is pain disorders, like did you not look at pain as an outcome? So it turns out that that's actually there's a linear relationship. It's not so much of a curvilinear relationship. It just, in general, as a total volume, the more activity you do, the better, in general, your pain outcomes are, and the reverse is was not significant. So, okay. So overall, these results tell us that the MEPA, as a subset of physical activity, seems to be beneficial for mental health in chronic pelvic pain disorders, and this is after adjusting for pre-existing psychiatric conditions and some other individual level factors. The pain-physical activity relationship might be linear, and maybe the pain self-efficacy measure outcome, it could be a more stable measure, i.e. a trait for some, but it is more responsive overall to the volume, the total volume of activity that includes all parameters or all intensities of activity, right? Now, in conclusion, this is just one way of looking at the complex relationship between some of these very prevalent chronic and often debilitating symptoms in chronic pelvic pain disorders and how they might be interacting with various health behaviors. And these findings could be similar for some other chronic conditions that also include these similar symptoms, which are prevalent across conditions that are chronic and kind of have flare-ups in the same fashion. And the methods, and therefore the methods discussed here can broadly apply to various research questions, conditions, data structures, and so forth. And with that, I'd like to thank you for your time. Here's how to reach me if you're interested. And these are all my collaborators on this ongoing parent project, which takes a village. So I'm very grateful to everyone involved. Thank you.